So what we have observed so far in CAR-T cell trials in the context of AML is a high incidence of severe cytokine release syndrome. So our approach using AdCAR-T cells will increase safety of CAR-T cells. These adapter molecules are small, they have like 52 kilodalton, so they are given as continuous infusion and their half-life is about 30 minutes. So if you encounter higher grade toxicity, you can stop the infusion of the adapter molecule, which is given as a continuous infusion, similar to some of the bispecifics, and thereby hopefully revert and stop the side effects. So this is clearly one of the advantages of AdCAR-T cells. So currently, also if you look at clinical government trials, most of the target antigen in the context of AML are CD33, 123, and CLL1. So about almost 90% of the clinical trials are following these myeloid lineage antigens, and these have the expected on-target toxicity on the healthy hematopoietic system, and therefore are mainly done as a bridge to transplant strategy. In contrast, CD7 is a more unique target antigen that is not expressed within the healthy hematopoietic system and therefore is more specific. It's expressed in about 30% of AML patients, and there has been really interesting data now presented and also published in the New England Journal of Medicine, where patients were treated with donor-derived CD7 CAR-T cells followed by an allogeneic stem cell transplantation, and these patients, except lymphodepletion, did not need conditioning or graft versus host prophylaxis. This seems to be a very interesting approach. However, what has also been seen, there is CD7 antigen loss and relapse. So I think probably we need to target multiple antigens to be successful. Otherwise, we'll always see antigen escape. So we know in AML that the target antigen expression is very heterogeneous inter but also intra-individual, so even patients have different clones with different expression profile of the same target antigen. So that's very different from the CD19 CAR-T cell field. So I don't believe that we can cure AML with targeting only one antigen. So with the adapter approach, where we have a generic CAR-T cell and the specificity is only given by the adapter molecule, we can exchange the adapter and thereby target multiple antigens, either in parallel or sequentially. So I think the big advantage of the adapter platform is that we can target multiple antigens. So I think 4 aspects have to be considered to improve CAR-T cell strategies or therapy in AML. First of all, we are currently using CAR-T cells in heavily pretreated patients after 3 or 4 prior treatment line. So I think we have to move bispecific CAR-T cells, CAR-NK cells into earlier treatment line with low disease burden. Second, I think we need to integrate targeting multiple antigens. We'll see antigen escape variants, so I think targeting 2 or 3 target antigens is going to be more successful. Third of all, I think as there is an immunosuppressive microenvironment, and a recent report that also T cells secrete cytokines that mediate resistance of the AML cells, that has been published by Zargil in Nature Medicine, we also need to combine, for example, with JAK inhibitors or other small molecules to overcome resistance. And fourth, also other strategies like combining it with strategies of innate immunity like STING agonists could be really promising. So I think currently our strategy is now independent of CAR-T cells, is very much focused on 2 aspects. Genetics of the AML, it's very heterogeneous, and we have some of the targeted therapies, but it's also prognostic, so we are looking at all the different genetic types. And the second really important aspect is MRD, so MRD response, MRD sort of persistence or turning MRD positive again. But I think in the context of immunotherapy, particularly CAR-T cells, we have to integrate the tumor microenvironment, sort of the health of the bone marrow, as a third factor. And unfortunately, it's gonna get more and more complicated with different small risk groups. And I'm concerned that this will not be very attractive for industry, because we have really small patient population if you stratify for genetics, MRD, and the microenvironment. So I think it's really the task of academic medicine to sort of propagate and develop AML-specific CAR-T cells. And unfortunately, but I think like everywhere in oncology, this has to be a personalized approach, although the numbers will get really small. But I think one-fit-all concepts are not going to work. So there are two strategies currently being followed in AML. One strategy is applying CAR-T cells, achieving a morphological leukemia-free state, preferentially MRD negative, and followed by an allogeneic stem cell transplantation. And with this approach, you eliminate all the CAR-T cells. So you only have efficacy of the CAR-T cells for a very limited approach. But at least you can target myeloid antigens, and aplasia is not an issue. And I think a very interesting evolving strategy is to do edited stem cell grafts. You delete sort of the target antigen by CRISPR-Cas, either the entire target antigen or by non-synonymous mutation, just the epitope that is targeted, followed by CAR-T cells. And there you have the advantage. The CAR-T cells are allowed to persist and they have longer activity. So we'll see how this turns out. And currently we have no clinical trial data for the second approach yet. So one of the major challenges, in particularly in the context of acute myeloid leukemia, is identifying a suitable target antigen. As you're aware, most of the target antigens currently being employed are myeloid lineage antigens. And there's a great concern of on-target off-leukemia toxicity on the healthy hematopoietic system. And as you're aware, in B-cell malignancies, this is less of an issue because we can live without B cells and substitute IgG deficiency with IgG replacement therapy. So that is not the case with the myeloid compartment. So identifying suitable target antigen in AML is one of the challenges. And the second challenge is that we have more resistance. It's more like a solid tumor with an immunosuppressive microenvironment. So these are the two challenges we address in AML. So I think besides target antigens and toxicity, another big issue in CAR-T cells in AML is resistance, mediated through the microenvironment, mediated through the T-cell AML interaction. So I think future strategies have to implement possibly other small molecules or conditioning regimens to counteract the immunosuppressive microenvironment. And I think we will not be able to just cure with a CAR-T cell, but do combinatorial approaches. So this is, I think, one of the future challenges we have to tackle.